Evaluating clinical evidence might seem like a huge task right now for you because you're just beginning, but you will gain competency and proficiency in this. You have to remember that excellence in clinical care requires that you integrate clinical expertise, which you're gaining now, patient preference, and the best available clinical evidence. And I'm not going to try to tell you it's not complex, because it is. But you already have the base of a registered nurse, and you will be able to integrate the information you're learning. Mastering the analytic skills that I've just mentioned will improve your clinical practice, and it'll ensure that your assessments and recommendations are based on the best clinical evidence. The process of diagnostic reasoning does begin with the history, and you actually get about 85% of the information you need from a good history. So as you learn about your patient and you're collecting the history, you'll begin to form a list or a differential diagnostic list of the potential causes for the patient's problem or complaint. You ought to start with the most likely explanation, but you can also include the most plausible diagnoses too, but limit those to 3 or 4, okay? And think about what you already know. So if after you take the patient's chief complaint is my nose hurts, you'll take a thorough history of using that acronym OLD CARTS or OLD charts that will allow you to thoroughly question. But I just want you to use your common sense, because you've got a lot of common sense. You're a registered nurse. I want you to think, well, what is the most likely thing that makes a nose hurt? And I have the information from the history. You know, your differential, your list of your top 3 list, if they got hit in the nose with a baseball, I would hope would include a fracture, possibly a contusion, and a possible just hematoma. And then if they had no trauma, the top 3 reasons why your nose would hurt might be there's an inflamed hair inside, there's a folliculitis, they're a nose picker, they could have a tumor in their nose, or they could have a fungal infection, a bacterial infection. So don't negate what you already know. So, and that could apply to any chief complaint. So what we mean by use the history and physical exam as a diagnostic test or tests is that often you might not need to do anything further. No additional testing other than that. Help that history taking and that physical exam to formulate a diagnosis and then the plan. So recognize, and that's the majority of the time. There are times when we do have to do diagnostic testing. And advanced nurse practitioners are not only responsible for ordering those diagnostic tests, but also evaluating the test results. So 2 of the major concepts to ask yourself is, are the tests valid? Are the results, the test results, valid? Does this test accurately identify whether a patient has a disease? And this includes comparing the test against the gold standard. Okay, and so you have to know what the gold standard is. And one example is the sensitivity and specificity of that test. And what comes to my mind is influenza, those for A and B, and strep throat, a rapid strep. Those tests. What's their sensitivity and what's their specificity? And then I've included some other ways that you look at validity of findings. Okay. Then the second concept is really is the test results reproducible? So it's one thing for a test result to be isolated, but for us to really be able to evaluate the usefulness, it must be reproducible. And I gave you an example of natural frequencies, but you can read about these in detail in your book, and you should, because we're responsible for this. This is an example of a 2x2 table, which helps us evaluate diagnostic tests. It's a basic format for evaluating the performance characteristics of the diagnostic test, which means how much the test results revise probabilities for disease. There's two columns, the patient with the disease present and the patient with the disease absent. These categorizations are based on the gold standard test. The two rows correspond with positive and negative test results. One of the very important ways that we do evaluate diagnostic tests is looking at the sensitivity and the specificity. So if a test is sensitive, it's the probability that the person with the disease will test positive. If a test is specific, it's the probability of the non-diseased person will actually come up with a negative test, because it can be vice versa. So I also included the positive predictive value, which is the probability the person with a positive test has the disease, another way of determining or evaluating diagnostic tests. With a negative predictive value of a test is what's the probability that person with a negative test does not have the disease. I did give you a URL for a 3-minute explanation on YouTube. It's great. It's brief. It's concise. The typical scenario, clinical scenario faced by NPs involves determining whether a patient actually has that disease based on the test results that is either positive or negative. And the relative test statistics here are positive and negative predictive values. But let me give you an example. If you do a strep test, a rapid strep test for a sore throat, and if you evaluate all the signs and symptoms of strep throat, but the rapid strep comes back negative, then you have to think, well, how sensitive is this test? Well, about 7 out of 10 are positive. They have the disease. It says they have the disease, but then it misses 3 out of 3 of them. They have the disease, but it says they don't have the disease. So you have to base your decision not just on that diagnostic test, and you have to understand the sensitivity and the specificity of that particular test. I could also reverse that, So your patient comes in, they have the worst sore throat they've ever had, but your clinical finding, your physical exam, is there's no white exudate, there is no fever above a certain threshold. Let's say the fever is never above 100, and the test itself, the rapid strep, was negative. So it catches 7 out of 10 now from what I just previously said, but it misses 3 out of the 10. Okay, so more than likely, when you make a clinical decision, you're going to think they probably don't have strep. Okay, now you're in a conundrum a little bit more so if the test is positive. Clinically, they don't look like they have strep from your examination, but the rapid strep says positive. And then you will have to base your decision on your exam finding, your test results, your patient preference, and the latest evidence. And you're actually going to learn a wonderful guideline to help you determine if someone probably has strep or doesn't. In this slide, we talk about prevalence of disease, and I want you to read that lengthy explanation in the note section of this slide, okay? But we're really talking about the proportion of patients in the disease column, the prevalence of it. So it's based on the characteristics of the patient population and the clinical setting, but look at that third bullet. So many diseases will usually be higher in older population or in those patients being seen in a specialist clinic. Okay, that makes sense to me, but I want you to understand about how we use prevalence of disease in making a clear, clinical, rational, reasoning decision. I do want you to be familiar with likelihood ratios. And those are the probability of obtaining a given test result in a diseased patient divided by the probability of obtaining a given test result in the non-diseased patient. And Bayes' theorem is the one I'm the most familiar with, but Fagin's nomogram is important, and natural frequencies are also important for us to consider when we are trying to determine the likelihood of disease. I like the example that is provided in your notes. It talks about trying to estimate how many alcoholics that you see, patients that are alcoholic, will actually have liver disease, and it gives you that example, so it'll explain it a little bit further. But just look at the usefulness of the likelihood ratios. I really appreciate the example. It helps you understand Bayes' theorem a whole lot clearer. On page 51, about a woman that comes into your clinic, how likely is it that a woman with an abnormal mammogram has breast cancer? So it goes through this example. It says a 57-year-old woman at average risk for breast cancer has an abnormal mammogram. She wants to know the probability that she has breast cancer. The literature states that the baseline risk, or the prevalence, is 1%. The sensitivity of a mammogram is 90%, and the specificity is 91%. So one way to use the likelihood ratio is to revise probabilities for the disease through the Bayes theorem. Okay, so the theorem requires converting the estimated prevalence, pretest probability, to odds using the equation. So I want you to go on page 51. Look how they did it. I'm not going to ask you to figure one out, but when you apply Bayes' theorem, you can tell her that the probability of her of that abnormal mammogram being breast cancer is 9%. Now, the probability of it not being is 91%. So I always start with the positive number. Health promotion as a nurse practitioner is absolutely vital. So you're just going to, throughout your education, continue to add to your knowledge of health promotion. We know that primary prevention are interventions designed to prevent disease, and secondary preventions are screening tests designed to find disease or disease processes at an early or asymptomatic stage. You know, the rationale of the secondary prevention is that if you treat early stage disease early, the treatment's typically more effective than treating late stage disease. So how do we decide the best recommendations? Well, we definitely use guidelines, and you will be exposed to a lot of guidelines as you progress through this program. The U.S. Preventative Service Task Force is one of the guidelines we use, but we also use specialty guidelines, American Family Physicians, we use the American Cancer Society, but the strongest health promotion recommendation are based on the results of actually synthesized multiple randomized controlled studies. So our book's a little outdated because it's really those systematic reviews instead of just a single evaluation. Review pages 59 through 63 on guideline recommendations. The very last slide, we talk about critical appraisal of evidence. Okay, you will be using evidence, and you should be using evidence throughout your entire career. And you have to ask yourself, if you are using a rigorous and standardized approach to looking at these studies, are the results valid? Can you believe them? What are the results, the magnitude and precision of that study? And how can you apply the results to patient care? Is it generalizable? So you must understand the concepts of bias, results, and generalizability in critical appraisal of research. I appreciate your attention today. Thank you.